best way to manage and learn how to answer questions on pharmacology is by using priority. I think your test will be full of prioritization, but they don't tell you is which of this you need to intervene, which of this the next should question. That means the medication they're giving you, there's something wrong with the body, and they're going to use the most prioritized information about that medication to worry about, and that is the prioritization. So we have a couple of questions, about 15 questions. Try your best to answer them before me, and let's take a look at it. Who do you see first? Who you want to see? Somebody that you should see because there is a problem. Somebody you should intervene because there's a problem. Something that you should question. If you don't do that, patient will have a morbidity. We don't want anybody to have complication. We don't want anybody to die, and we don't want anybody to miss anything that will lead to complication for a patient. So these questions are designed for you to think so that you can know that, hey, this problem is not good. So either you see the patient first, you intervene, or you question disorder. Select or apply. And currently, select or apply, you just have to pick those that you're confident. You don't guess. If you don't know, you just leave it. But I think you know all these answer choices. Let's take a look at it. A client with a seizure disorder, right? On tube feeding via gastrostomy. So that's the halfway. In a prioritization question, half of the question is the situation. And then the next portion is what is the problem now? It's getting 2 feet to gastrostomy. And the dose of phenotime is held for 2 hours. Why would you do that? I have a seizure disorder. I need my phenotime because I'm getting 2 feet. You've held it for 2 hours. Do you want to see this patient? No. This patient does not need to be seen. Phenotime, hate protein. So whenever you're having a protein diet, you have to avoid giving patient any 2 feeds. Otherwise, it will affect the absorption of the problem of the phenotype. So either you give it 1 hour before you start the 2 feed, or when you start the 2 feed, you gotta wait 2 hours before you give the phenotype. Otherwise, it won't be absorbed, and it's a waste of dose. And so this is good. The nurse is doing the right thing. Being fed with a feeding tube, which is the feeds maybe all full of protein, phenotype should be held for 2 hours. So I don't need to see this patient, even though I have a seizure. No. A client on phenotime and a small maculopapular rash on the chest. You want to see the patient? This is a little bit of rash on the chest. I think you should see this patient. Phenotime is a sulfur drug. And sulfur drug, one of the serious complications is Stevens-Johnson syndrome. And how do they present? A small rash on the chest first before it spread throughout the body. We should not wait until the rash has spread throughout the body. A tiny rash on the chest, just one single small maculopapular rash on the chest, is your early indication to avoid any catastrophe on patient going into sepsis. And that is a B-sharp moment. And therefore, we should see this patient. It's a Stevens-Johnson syndrome. A client on atorvastatin and now 4 weeks pregnant. Statins are teratogenic, and therefore, or teratogenic, and therefore we should never give it to a pregnant patient. She probably may be taking it already, and now she's pregnant. We need to stop it. Otherwise, we have a baby with a defective organ. So we have to see this patient. A client with end-stage liver disease and albumin is 2.5. I have a liver disease. My albumin is 2.5. Oh, it's very, very low. I need to see you. No, you should not see a patient who has a liver disease with albumin of 2.5. If you have end-stage liver disease, your albumin is low, your PT and iron now, both of them are high. Your platelet, it's low. Okay, your bilirubin is high. All this is expected finding. Therefore, we don't need to see this patient. A client with fluoxetine who was what? Fluoxetine was changed to selegiline within 1 week of stopping the fluoxetine. Listen carefully. I'm on fluoxetine. The medication was changed to selegiline within 1 week after I stopped the fluoxetine. So you have an SSRI, you stop it, and then within 1 week, you start a MOIs. What do you think? That's a problem. You need at least 2 weeks of washed out moment so that all the SSRI can get out of the system. If you don't wait 2 weeks and you give them a monoamine inhibitors, what will happen? You have a problem. You get serotonin syndrome. So we don't want a serotonin syndrome. So this patient needs to be stopped right away. We should not, they have not allowed enough time for the washed out period to occur. Within 1 week is bad. At least 2 weeks. Wait for 2 weeks, then you can initiate another medication. So we need to see this patient. So who do we need to see? Yeah. Number 2, number 3, and number 5. Okay? Pharmacology. So let's continue. Who do you see first intervene and question? Another group of cases. A client prescribed what? Trazodone for sleep, now with what? Sustained penile erection for 3 hours. You want to see this patient? I think you should see. In B sharp, I talk about pain that will make you lose your limb, life, and eyesight. This patient, if you don't see them, they're going to lose their limb. They don't like it. Sustained penile erection, this is priapism. And trazodone is number 1 cause of priapism. Yeah, and sickle cell too can do that. But this is priapism due to medication. You need to see them as soon as possible. Otherwise, they will lose their limb. Okay, so I see this patient. A client on Zapraxidone on magnesium level of 1.2. This is low. It may be normal because for some people, but this is low normal. I'm worried about it. It's too low, 1.2. I mean, I want something 1.5, 1.7, 1.8, but it's too low for my liking for somebody who is on Zapraxidone. Okay, what does Zapraxidone do? It prolongs QT prolongation. That's one side effect. And what does magnesium do? Low magnesium also causes what? QT prolongation. These two can potentiate the effect of multiple QT prolongation. And what do we have? Tosad Pontes. We have 2 medications that causes QT prolongation. If you combine them together, we have Tosad Pontes. This is dangerous. It's a ventricular tachycardia with the polymorphic features. Therefore, I need to see this patient. Okay, a client on carbamazepine and a runny nose for 1 day. Oh, his nose is running for 1 day. What do you want to do? Do you want to see this patient? I have carbamazepine and my nose is running for 1 day. I think you should see this patient. Carbamazepine is a seizure medication. It's used for seizure, but one of the complications is agranulocytosis. Agranulocytosis. Agranulocytosis means their white count is low. In a single URI symptoms, or any diarrhea, okay, any runny nose, any vomiting, anything that tells you they have or gastritis, any signs of fever of like 100, any signs of infection, you should see them. Otherwise, they will have a B-sharp moment, sepsis. Therefore, runny nose, you should not take it lightly. I need to see this patient. Okay, so that's for that particular patient. A client with coronary disease prescribed sumatriptan for migraine. What do you think? I have coronary disease and you prescribe sumatriptan for migraine. This is the medication for migraine, sumatriptan. But what does it cause? Vasoconstriction. Because of that, it can increase your hypertension. It can cause vasoconstriction and decrease blood flow. This can precipitate coronary disease, so it can lead to MI or uncontrolled hypertension. Therefore, we should avoid it in patients with hypertension and coronary disease. So we should see this patient. You seeing the picture now? Yeah, that's the idea. You have to break it down, divide it into two, and bring your content and realize this is a problem. A client with type 2 diabetes prescribed albuterol for new diagnosis of asthma. Think about it. Albuterol is an agonist, right? It's designed to help with the beta agonist. The beta agonist, what do? They speed up everything like epinephrine. So your heart rate goes up. Okay. You have palpitation, you have anxiety, you have tremor. So every time you give a patient with albuterol, you expect their heart rate to go up. All these things are going to happen because it's a stimulant. It's like epinephrine or your glucose, like a pheochromocytoma patient. Yeah, their glucose goes up. So glucose go up to help with the energy that you're going to burn. So they will have hyperglycemia. In a patient with type 2 diabetes, yeah, we need to adjust their medication. Okay. But is this patient a priority to you? Yeah, we have time. I mean, they're not going to die from it by their hyperglycemia right away. So this patient does not need to be seen immediately among those 5 patients we have. So it does not need to be seen immediately. We have time to adjust their medication. So even though this is not a problem, giving albuterol to um, diabetes patient, all you need to do is probably if they take metformin, you may have to go up on the dose, but that's not something that will kill them right away. As you can see, these people, coronary disease with some triptan will increase their hypertension and let them have MI. This patient will have sepsis, so it's worrisome. This patient will have cardiac problem, QT, and shock. This patient, okay, is normal. No, this patient, he has praxism, so we got to see. So this is a dangerous thing. This is a dangerous problem. Okay, this is a dangerous problem. This is a dangerous problem. But this, we have time to do something about it. So you don't need to see that patient. And number 3, who do you want to see first? A client prescribed what? Theophylline and prescribed cimetidine for GERD. Okay, patient is theophylline for probably an asthma. Okay, it's a bronchodilator, and then giving cimetidine. When you're on theophylline, I call them the 4 C's. These are the 4 C's you should avoid. You should avoid caffeine, so coffee. You should avoid ciprofloxacin. This is an antibiotic, fluoxetine. Okay, it does. You should avoid liver injury, which is cirrhosis. You can't give it to the patient with cirrhosis. And you should avoid cimetidine. This is number 4. The 4C, cimetidine, caffeine, ciprofloxacin, and cirrhosis. These 4 you should avoid it. Otherwise, you have toxicity of theophylline, which has a narrow therapeutic effect. That's a problem. Therefore, this patient need to be seen. A client on streptomycin for active TB and a creatinine of 2. What are the side effects of streptomycin? Think about it. Divide the question into 2. What do I need to know about streptomycin? It causes ototoxicity, it causes nephrotoxicity, and it causes hepatotoxicity. So all the 3, ototoxicity, hearing, nephrotoxicity, hepatotoxicity. So hepatotoxicity. So this is a problem that when a patient is taking this medication with a creatinine of 2, nephrotoxicity is a problem. So your kidney function will worsen and become more toxic. Therefore, we should see a client with urine output of 800 ml per hour after brain surgery was prescribed what? Democycline. Think about it. I have surgery, and all of a sudden I'm peeing 800 ml in an hour. That's too much, right? You're not supposed to. Everybody who have brain surgery, they are at risk of what? DI or SIADH. So what condition does this patient have? It's peeing too much in an hour. So this is diabetes insipidus. What do they need? ADH. Give them their ADH. And how do you give them? You give them vasopressin or demipressin. Okay? Desmopressin. You give them desmopressin or vasopressin. This is a form of ADH. We don't have direct ADH. This patient was given demicycline. Demicycline block ADH. That's the wrong medication. We should be giving desmopressin or vasopressin to help with reabsorption of the fluid. Therefore, we need to see this patient wrong medication. So that's a problem. A client with CHF prescribed risoglutathione. If you've never seen these patients before, these medications before, you should pay attention carefully. These are medication we give it to diabetic patients, and I call them the zones. They are the zones. They have the first name, something risoglutathione, or there's other group of them, but their last name is zones. When you see them, worry about it. This is for type 2 diabetes. It causes fluid retention and it leads to heart failure. It can cause MI. So these medications are very good diabetes medication, but they have serious side effects. So the zones for type 2 diabetes, risoglutathione. So the zones, when you see a medication with the last name of zone that is given to a diabetic patient, worry about CHF and MI. Therefore, this patient already has CHF. You know what to do. We got to see you. Lastly, for this page, I think there's one more. A client on sulfonylurea who drinks 5 beers a day. What you should connect? Sulfonylurea and drink 5 beers per day. This is a diabetic medication and it's a sulfur drug. This sulfonylurea causes profound hypoglycemia. So because of that, we don't even give it to older people. We avoid it in older patients because it causes profound hypoglycemia. Alcohol, guess what? Also causes hypoglycemia. You develop diuresis and you have like excessive urination, and you develop hypoglycemia. Alcohol causes hypoglycemia. Sulfur causes hypoglycemia. You have two problems causing hypoglycemia. Yeah, we need to see you. We need to tell patients who take sulfur not to take alcohol at all because of they will have profound hypoglycemia. So we see this patient, we see this patient, we see this patient, we see this patient, we see this patient. All of them need to be seen because they have bad problem. If you don't do anything about it, they're going to die. Okay, and lastly, so 20 questions. A client on alendronate, right? And upright 30 minutes after taking med. So what is alendronate? This is bisphosphonate. And so when you take it, your esophagus, they irritate the esophagus. So when you take it, you want to stay upright so that whatever medication will just go quickly through your stomach and empty it out. Otherwise, it will irritate your esophagus and it can cause strictures. Because of that, we take it with empty stomach. Those are the two things, empty stomach for bisphosphonate and staying upright for at least 30 minutes and a full glass of water. You need a full glass of water to take them. So this patient is doing the right thing. He's taking alendronate, last name dronate, bisphosphonate, and I'm up 30 minutes. It's good. I don't need to see you. A client allergic to amoxicillin prescribed penicillin G for syphilis. This is a hard one, okay? This is a content you have to know. When you are allergic to amoxicillin, the cicillins, the penicillin derivative, you should not take any more penicillin medication. If I'm allergic to amoxicillin, penicillin will also react with that. But what is the problem? I've been giving penicillin G for syphilis. Yes, syphilis, the best treatment is to give the patient what? Penicillin. Even if you're allergic to penicillin, they will something they call desensitized. They will give you small dose of penicillin and see how you react to test your body to desensitize it. And then as soon as you finish desensitization, they'll give you the penicillin because this is the most effective medication we have. If we don't give it to you, we get into trouble. So most of the time you'll be desensitized and then giving that medication. So this is not a problem. A client on azithromycin for UTI and ziprasidone for schizophrenia. You know what I'm leading you to. We know this causes QT prolongation, right? Guess what? All the mycin, there's three of them. Erythromycin, they call it the macrolide. Azithromycin, erythromycin, and clarithromycin. These three, okay? Azithromycin, erythromycin, clarithromycin, they also causes QT prolongation. So we got to watch for this medication. Erythromycin, azithromycin, and clarithromycin. Those mycin, specifically these three groups, causes QT prolongation. 2 QT prolongation, we call Tosad lipontase. That's what they're going to cause. Therefore, we need to see this patient. A client with ADHD taking amphetamines at night. We know you need a stimulant, but the stimulant should be taken during the day, early in the morning. So morning, because what? It causes insomnia. If you take it at night, you're not going to sleep. So that's a problem. Intervention. A client on scopolamine patch and the dry mouth. What is scopolamine? It's anticholinergic effect, right? It has anticholinergic effect. And what does it do? Anticholinergic causes what? Dry mouth. This is an expected finding. You get constipation, right? You get urinary retention, you get dry mouth. So this is an expected finding. We don't need to see it. So we just have to see 3 and 4. And as you can see what I've done, I break the question into 2. The issue first, what is the main thing, and what is the problem? And then you combine those 2 and you can figure out what is the problem. This is how you answer who do you see, who do you interview and question. Once again, take care of yourself. Subscribe for more content like that, and all the best of luck. Take care.